I thought we were going over putting them in. Some of you guys will hear more about how to deal with them once they're in.
True.
Correct? So that's a separate lecture. I'll try to hit some of it, but that's a whole different thing.
Oh, well then.
So,
Because we don't put them in.
what's that?
Are you giving me a hard time?
That's okay, it's okay to know the information.
Yeah, we'll learn.
Knowledge is never bad.
We help assist, but.
So how's this thing
Right.
advance? So, yeah, up to ding. Yeah. All right, well, anyway, thanks for coming. Basically, this was about, I thought more about insertion for people in the ER is what this was about. So, this is, so chest tubes, why do you put them in? So, so what do you know about, pneumothorax, tension pneumothorax, simple pneumothorax, that sort of thing. Basically, there's two different ways that people breathe. When we're normally just breathing, we're breathing by negative pressure or positive pressure. What do you think?
Negative.
Yeah, negative pressure, because your chest wall, there's no muscle. There's a few muscles in the proximal bronchi and that sort of thing in the lung. But the muscle itself has no muscle. So, or excuse me, the lung itself has no muscle. So it's not gonna. The lung's not moving of its own accord. The lung is responding to the environment it's in, which is in the chest cavity. And the way we're built, and this is different than dogs, just as an aside, but some animals, but the way we're built is that we have two separate closed systems. We have one on the right side, one on the left side. Animals, if they get pneumothorax, typically, they don't have a 2-engine airplane, they're a 1-engine airplane. They don't go, not. So, anyway, the way that the lung works is by negative pressure. So the chest wall expands, the lung, which is very compliant, it's almost like a bubble, will expand to fill that space when you create that negative pressure by expanding your chest wall, your whole chest cavity. So it's passive movement expands. So what happens if we convert, that's negative pressure breathing, which is what we all do. What happens if we convert to positive pressure breathing? When would we do that? When would we go to positive pressure breathing?
When the baby's born?
Well, that's, the baby's born. Yeah, it can if you intubate them, right? So what happens when you intubate somebody? They're no longer breathing passively. That's the reason that the lungs aren't expanding passively, because you take over, typically you give them neuromuscular blocking agent or something, you take over, or they're not breathing because they're just right? You take over breathing for them. So you convert it to a positive pressure system. So now you're putting force in through the lung to get it to expand out to the chest wall. So what can happen is that space between the visceral lung, or the lung itself, and the chest wall, parietal, that difference in space. So what can happen is, especially if you get into traumatic situations, or if that one of those little bubbles pops, and now it's putting out air, but then it has no place to go. If it has no place to go, then you're using positive pressure breathing, you can get a tension pneumothorax, right? So the air goes into that space between the lung and the chest wall, that'll push things, right? So if a tension pneumothorax is caused either by air coming in, which shows it from the outside coming in and not being able to get back out, or by some sort of trauma to the lung itself, so that there's a rupture and the positive breaths that you're giving go into the chest, but then obviously that's the difference between, and a simple pneumothorax would be if there's a hole or a big trauma and you've got air to go in it. So when you talk about putting in chest tubes, we're really talking about pneumothorax or hemothorax. When we look at an X-ray, we'll see what kind of difference between a pneumo and hemothorax.
Blood.
Yeah, you see blood, but you see, and on the X-ray, it'll look, one will look really sort of just like that. That was empty, right? On the left side of it. It's supposed to show you. So you can see that black space, that's air. It'll look on an X-ray, it'll look white, the hemothorax, because that's blood. So it has the density that will reflect the X-ray. And what it shows you on the little diagram there is on the what would be one over there, where it's all the mediastinal structures are deviating to the opposite side. That's attention. And that's what we're, so this is so if you're gonna save somebody with a tension pneumothorax, typically it's gonna be pre-hospital medicine. If we diagnose it by the time they get transported and know you haven't done anything, they're probably dead. And that's where you, that's a classic case where you see PEA, pulses electrified. So there's, anytime you run into somebody that gives you a hard time from a needle or something, I know we're healthcare professionals, so I'm looking, I thought it was a pneumothorax, that's what I did. You should get that. So, and where's the easiest place to put in a needle thoracostomy?
Mid-claviculars.
Yeah, clavicular line about the third or fourth interspace. So you just right here go down about like basically a hand rest from the clavicle. What do? You go under the rib or over?
Over the top.
Over the top. You got a question?
No,
Okay.
it's-
Doesn't look like it.
I know, I'm just learning.
You're still going right. That guy's an idiot with that.
No,
Great.
I'm
So anyway, that's the best place to go. What kind of needle would you use?
IV catheter, largest you can get.
Yeah, largest you can get. And typically, we'll just leave the needle in it, so you don't want it to collapse with the catheter itself. But that's, and then, other places around the world, they'll use what they call finger thoracostomy. They'll make a decision to put your finger in there just to convert, because if you convert, especially if you intubated somebody, if you convert them from a tension pneumothorax to just a pneumothorax, a simple pneumothorax, you've actually done them a favor. Because then if you put your finger in, the hole's big enough that the air is going to go in and out, and you're breathing for them anyway, so the lungs expanding. It's like, okay, who cares? So next one. All right, chest anatomy. This is what you got to know for putting one of these things in. So there's, talking about the mid-clavicular line. You put in a little bit of needle, that's fine. But probably the safest place to go, you can go upper over on that side. Safest place that you can go is where the pectoralis muscle is here, latissimus dorsi is here. You go about just below the hairline. If on a woman, you go about hand breadths below the axilla. Right there in the anterior axillary line. So the anterior axillary line is right up here in the front, mid-axillary line is right in the middle, and the posterior axillary line is in the back here, this place. Because what lives there? What are you worried about going to other places? You get into nerves and veins and arteries. So that's basically the zone of safety right there, just below the hairline and the artery. And you're aiming for about the fourth or fifth interspace. So if you're going to the mid-axillary line, the other thing that's nice about it, the person's up supine on the table, and you're going in the mid-axillary line, you're directing a little bit down, it's not a big deal because you're going to do a lot of chest space. It's a three-dimensional structure. When the lung collapses, it collapses not just from side to side here, it collapses front to back. So, we'll go over that in a minute. Then the other really critical part about the anatomy when putting in the chest tube is all the neurovascular bundle is actually hidden underneath the rib. There's really a groove in there where it all rides inside. So it's actually, we are incredibly fearfully wonderful. But anyway, it's intercostal vein and just this is a board question. Anyway, what lies underneath the rib there is the vascular bundle. It's a main artery there. So, all right, next one. So here's the tray. Go over this. So this is a pigtail catheter. This is with the obturator in place. So the pigtail is this part. When I pull this obturator out, pigtail. Put the obturator in, it should straighten it out. And there's and what happens is it's a cell technique, so you do it over a wire. Right? So, and this has the offside is where this points. So if you were going to put it in, you got to put it up like this to get the wire to go through, because it's got to be pavement to the side. But once you get it in, obviously, just give up the suction wherever you're going to do. But if they have a tension pneumothorax, do you need to put it to suction right away? Is that what's really going to help? Just the placement in there, and you hear it rushing. It's pretty cool. And then typically, like a PA situation, a lot of times you get return circulations. Obviously, we're not going to do this, but that's to create a sterile field as much as you can. Since I told you about doing this mostly in pre-hospital environment, as sterile as you can. Don't let being sterility beat speed. So kind of balance. What's this? Funky little deal, pass it around. It's a Heimlich valve. So it works one way. Basically, there's two pieces of plastic right here. So air can go this way, but if it tries to come back in, it'll collapse. So air out, not in. You gotta put it in the right way, right? So, and it shows you that.
What does it connect to then?
It can, yeah, it'll connect to the chest tube itself, which in this case it has a way to up-dilate it, or to connect it to, it doesn't have to fit. But there's a way to connect that to a standard chest tube so it expands. So that the tube itself is,
Yeah.
so it has an adapter. It's
Okay,
kind of like
yep.
plumbing supply store, I guess, or what's right there, it's plumbing supplies. So, steps to putting this in. First thing is you use a needle to raise a skin, just a skin wheel for local anesthesia. And you're also going to want to raise a skin wheel where you're going to put a stitch in so that you can there you go. Zoo.
That's why you wanted me to do it.
So you raise that skin wheel. The other thing you can do is then you can use it like a finder. The thin needle that you have in here, you can use it as a finder to go down to the rib. You're going over it, not under it, and just inject a little bit of blood anesthetic until you get in. You see how deep it is. A lot of times with an adult patient, you can't. If you use one of these needles, you're not going to be able to get all the way down to it. So when you're using one, you may not need to get to the rib. So then hook this up, and when you do, there's take the 5 cc syringe. This is 3. We'll use this. You want to put about 2 or 3 cc's in it. I like using the smaller one because it's just easier to control. And when you watch out for the sharps, I did say something about those in here. Line up the bevel of the needle with the numbers, so that you know where that is. And you'll notice that this is about 2 or 3 millimeters in length from the tip to the end of the bevel. So you've got to put, once you get air back, and what you're going to do is you're going to put about 2 or 3 cc's. I just use local, typically 3 cc's. And the reason I'm doing that is I want to be able to inject a little bit of local as I'm going down. The thing that's going to be the most sensitive when you're putting this in is the lining of the pleura right up against the chest wall. And so that's the one you want to get just before you push through. You really want to dump a half or a cc of local anesthesia. Once you get in, though, with that bevel, you can get where you can get a little bit of air, but not really be able to pass the wire very easily. You want to advance at least another, like I said, 2 or 3 millimeters in. And what you'll notice if you leave, that's the reason for leaving 3 cc's in there. I'm not going to use all of it. By the time I get down to the right into the lung or into the space between the lung and the chest wall, I want to have about a cc. Because then what I'm going to do is I'm going to start drawing back, and as I get in, 2 things will happen. This will go whoop, but I also see bubbles. So once you get that, you got to stabilize this. You'll pass that off. Then you're going to pass the wire through the, and you've got to pull that out so you can introduce it. You pass the wire through. It's nice to have help if you can do that, because they'll be able to stabilize this on the end. As you're holding this, you never let go. So you advance that, and you can see we're through the needle, but that's how much, to do the red part, that's how much wire you had to put in to get it in. And then you just advance this further than that. You want to be able to control it, advance it into the chest. Then over that we'll go, once you have the wire out, then what you're going to want to do is before you pass your catheter, is you want to take this and go right along the wire. So, and you want to go, there's a bevel on the other side here. You want to go down to that bevel. You want to get it wide enough so that tube goes in. See that bevel on the other side? Right there. And it turns. So you want to put it in. And even if you go further, it doesn't matter. So you want to at least get to that point. Because this would be the, teaching residents and stuff, this is the most common mistake they make, is they make little bitty nicks. And then when they try to get this bigger tube across the wire, it hangs up right at the skin and they freak out. So if the incision's a little bit, it's a typical thing for surgeons to say, the incision's never, you never want a too small incision. If it's too big, who cares? It's another stitch. So you wanna just advance it across the wire until you get in, and you can see, you wanna get all those into the chest, right? So you're gonna put this tube typically down to, you know, this is supposed to be small, medium, large person. But typically around here, we got a bunch of farmers and stuff. Everybody always worries about, why do I look like Twiggy? It's like, 'cause you were never supposed to be Twiggy when you were around here, you know, or a little bitty person to work at farming, so. So anyway, you're gonna want to, for the, you know, this would be the rural Iowa. And that's not a cut. You gotta be able to work. So anyway, and then once you
Or
put it
they
in,
have worked, and that's why.
yeah.
Hey, but I have,
Sure.
so when you put that tube in, does the bevel go up or down? You're holding it, like, the bevel into that tube, does that matter?
So this is as straight as it can get without
Okay.
having the dilator come out.
Okay,
So it'll go right through the dilator, and
Okay.
then even though it's like that, you can
Okay.
feel it. It's pretty stiff right
oh, it's not even beveled, really, it's just,
there. Yeah, that's the reason you gotta have that, make that incision a little bit bigger. And
Okay,
when you
yeah.
get down, as you'll find out when you put it in here, when you get down, this one's not as tough as a human being. A human being's gonna be even thicker, and that's the intercostal muscles that are between the ribs. And it takes force. I mean, it's like, so. And when you do put it in, you wanna put it in where you've got the wire through here, and you've got the tube, and you're doing this as you go down. So you know, one, and not, yeah.
and
You know,
this is the
we'll-
head.
Well, so the head would be up here, you know, here you're in the armpit, you're in the anterior axillary line. And you're directing it with this, it doesn't matter.
Oh.
So you can go, yeah, with the trocars, obviously, the wire's in, you can feel this. You're not gonna. That's,
Plus, that's very flexible. So
yeah, it's meant to coil. This is, as far as direction, it doesn't matter. So you can pneumothorax up toward the apex, hemothorax down toward the base. That was always kind of a little bit of a hokey kind of thing anyway, but, that doesn't matter. With this, once we get it in, it's gonna, and we pull this out, it's just gonna coil up. So if I pull this out, right, it's gonna coil up, and as long as you're in, and it's super flexible. So this is way more flexible than chest tube.
So step one would be numbing it up, lidocaine,
Yep.
10-15 cc's in.
I don't think, I'd use, 5 to 10.
Okay.
That's
And then
enough.
and then also use that needle to,
Right.
for deeper.
Once you get down, because, yeah, you're not gonna, with these smaller needles, you're probably not even gonna get down to the intercostal space.
Yeah.
So with this, I would go in there and typically I'll use a 5, but it does have, we've got a 3 or a 10. But
So
anyway,
you could use the same one for like the superficial and then also for the deep.
you could, I think this, in this kit, I think this is what they're using for superficial, and this is what they're using. And this is a little bit more bulky, so not quite as nice, but the 5 cc is what I typically use. And, you know, line it up with a bevel again, and you're going in with that. And I at least start out with once I'm going deep, I start out with about 3 cc's. I want to deliver at least a couple of anyway.
And then how deep we go with that needle?
With this needle, that's what you're doing. You're crawling over the rib, right? You go down, so you're typically going, and this is different than a chest tube. So a chest tube, you're going to go 1 interspace below, and then try to get it to tunnel up to go into the interspace above where you put the tube itself. That's not what you're doing here. Here we're directly accessing this, because when this something this size out, it's unlikely that it's going to have a problem with, you know, creating pneumothorax from having it removed, and all that soft tissue will close in front of it. So anyway, so yeah, you're going right in. So I would go at the bottom of the rib, so I'm going up a little bit, and then I'm going to sneak over the rib, and I'm injecting. And what I'm doing is I'm waiting until I get that air. Bubbling in air, right? So the bubbling in air will come once I get into the potential space between the lung and the chest wall. I'll advance it a little bit further so that I don't lose it and then I'm stabilizing this the whole time I'm there. So you're right, there's no set number, and it'll freak you out too when you get a big guy. This thing might be hubbed when you're in. And the other thing is, we go back a slide, if you go back one. That space, what's the difference between that space and the midclavicular line, that space in the axilla? bunch of muscles in front of the midclavicular line, you've got all the intercostal muscles, plus you've got the pec major and the pec minor that you're going through. That's a lot more muscle. The muscles are obviously easier, harder to go through than fat. So that space should allow you to get in easier, especially in a gap.
So whenever you start noticing the bubbles, that means you probably went a little too far, then you got.
No, that's actually the right space. That's the right space, and you'll have a loss of resistance too. What you want to do is advance just a little bit further so that it doesn't become dislodged from that space. Well, so we're doing this for a pneumothorax or a hemothorax, so the lung is away from.
Oh, that's true.
So you shouldn't be. You shouldn't hit the lung. Yeah, you can probably advance about 2 to 3 centimeters. But it's a complete pneumothorax, you probably have it. So once you get it in, so big things, got to walk it over the rib. We're starting at when we're putting in one of these, the needle one, the Wayne catheter. It's kind of funny that we're at Wayne County Hospital, it's a Wayne catheter. So we're going in, so if we're going in on the side, we're feeling where the rib is, and then we're going we'll make our local anesthetic little wheel right at the bottom edge of that rib, and we're going to go right over the top. So this doesn't have any fat really over it, so I just go directly in it. And then we're waiting for that loss of resistance and the bubbling. And we advance it just a little bit further, take off the syringe, we advance the wire. Typically, I'd always have help doing this. I wouldn't do it alone. I don't like doing anything alone, but anyway. Because you can have people hand you stuff, and you've got one hand that's out of commission. Hopefully, your non-dominant hand that you're holding that needle in place until you get the wire. When the wire comes, the needle comes out over the wire. The mistakes I've seen is they don't get the wire in far enough. They'll put the wire in and they think, oh, it's in that far. Well, that's from the top of the needle, plus the reducer sheath. And so you gotta put the wire in pretty far. Then you may have to pull it back a little bit because you don't want to go so far that you get past the point where you can control the wire.
Would you be able to show?
That's right. So this wire just fell off. You can ask questions at any time. I can do 2 things at once. I can't do more than that. So this will go through here. So that means about needing help. So that's another mistake people make. This is the off position. That means this is on. So the wire will just pass right through that valve. So we're going to advance this all the way, and it'll come back out the other side. And it passes a little, because of that, just like somebody else said, because of that little tip there, that it passes a little bit rough right there, because it kind of has to bend across. And so once we got that out, then we can take so this will go in. We want to be able to control the wire at all times. So then this will come out, it says, and so somebody else will be controlling the wire. I'll be you. So, and then we'll pull this out.
Am I supposed to?
No, you don't want to pull back, right? Sure. You want to hold right here at the tip.
Okay, I got it.
And I'm gonna pull this back, and so it's coming back, and then it pulls out too. Other questions there? The next one.
Wait a minute, I do have a question.
Sure.
So when you have that long needle in,
So this went in,
yeah,
goes
And then
in the
how do
wire,
you-
then this comes out, the wire stays in.
okay, so you put the wire over that needle. That
The wire
was
goes
in it.
through the needle.
Yeah, that's what I meant. And then
And
it
it
comes
comes
out. That's what I wanted.
This
Okay.
wire.
This wire is in.
Okay, yeah,
I'm doing that. Okay, so this is.
You're gonna do it.
which is a,
I promise.
Sorry.
So this is gonna be thin just like this.
and then you're gonna, yeah.
All right, let me do one.
Yeah.
Because what happens if it has to happen on the floor and you have to help?
Literally,
Oh,
Dr. Wells said to me, if that
I
turns
mean-
into a pneumo, we'll probably have to put a Wayne catheter in. And you know what I was like in my head? What the heck is that?
Oh, yeah, I
And
wanna
was
know
on
what it
night
is, but
shift.
you think
It's
we're gonna
good
be
to
finding
know.
the spot for the
Well,
No,
it's
ma'am.
good to know.
Yeah, absolutely. But my questions are about managing.
I wanna Yes. watch.
Because that's where we
All right.
have the problem.
It's a fire.
Well, that's it. It seems to be very, subjective.
We're gonna use-
I mean, just looking at this.
So we've raised the skin whale, we'll use one of the smaller needles there. You put in 2 or 3
Insertion
cc's
much better.
of local.
If they want us to get one.
Now we're
this
gonna
is what
take
we wanna
this,
bring to
we're
them
gonna
and
pretend we're in the
encourage them to use this,
anterior
because
line.
the is like tiny
Set this up so that we're,
Yeah.
chest
the
tubes.
bevel's
They're
up
more
with the numbers.
functional.
We're gonna walk in here. Feel, and what we're gonna do is, I don't have any liquid in it, over there. So I'm gonna, so I can't pull back, right, because I'm not through yet. Pull it back, pull it back, pull it back, pull it
It's
back.
kind of like,
Alright, there we go.
Oh, wow.
epidural.
Yes.
Oh.
That's what I
There we
just
go.
said.
We're in.
Oh.
Coming from the OB
Oh, wow.
nurses here.
So, we're in,
That's
now I'm gonna take a, I'm gonna take the wire. So we'll hold the other.
While you're going in, you're just kind of injecting with lidocaine then too, or?
I would be in that case until I got down where I was in the, then I would stop doing it as I was
Down,
out.
and then it's kind of retracting.
Yeah, yeah. So now I'm introducing the wire's passing easily. I'm gonna get the wire, and I'm gonna take the needle off. Then, right at this step, I'm gonna take I make the little incision here. And I'll just push through. So it's there. And I've got this. I'm gonna have somebody help me control the other end of it. You can see the wire is really quite long. I'll push this over the top. Wire. Alright, and this is the part. This is actually fairly realistic. Yeah, it does have one. Yeah, we didn't make some. There you go. Didn't make the incision big enough. Very common mistake. So this thing.
Hold still.
It's a data.
That's a really good, that's a really good indication of just how hard you have to push that wire, or excuse me, how big they have to make that decision. You know, I would, typically, I was making, when I was working on it, it was a little bit harder. I would make it all the way to the hub. Just learn something after.
And that's the head, right? So.
Yep.
And you made it just inferior to that, right?
I
Lateral.
was pretending I was in that space up there, so it wasn't actually.
So in the axillary.
Well,
Anterior axillary line, so anterior axillary line, medial axillary line, posterior axillary line.
Okay.
what I mean is, like, when you put this in, you were.
I mean, yeah, I did it right where the wire was, so I want to incorporate where the wire is in the, and I just push straight in, and I just hopped it. So you just, it will not let me get through. So then it's in, I think it's in. It's in.
That's like your x-ray, right?
Yeah, well, the idea was that this would go over there, this would be in
Yeah.
there, and this would go over there, and everything would be tight, and what's happened is that this is not very tight, so,
Yeah.
you know, when I do this again, I'm gonna,
We'll just have somebody hold it.
Get a
well, what
glass
I'll do is,
pan.
no, I'll just take big like number 1, suture that, suture this, and just tie it on the bottom.
I was hoping we'd have a water sealed device, but I guess we don't. Heidi told me we had, probably have an expired one, but.
He said that's his next education level.
Yeah, I'll
I mean,
deal with the
just
chest tube
like-
one. I thought I was just teaching people how to put this in, so, yeah.
I was
This is
hoping we could
great.
just at least.
Yeah, we could go
I
and-
can figure out how to like set it
Yeah.
up.
Yeah, because
Have
that's,
somebody make a kazoo out
now
of
you
it.
guys are done, and now we gotta manage
So
that.
where does this?
That's what we.
Well, this, you're gonna have to have an adapter. It's not, I don't see in this kit, but you're gonna have to have an adapter that will hook up to this, so that then you can, it's not a plumbing job. And when you do this, it'll show you that,
It's like the blue.
yeah, yeah, the blue's gonna go down. The reason it's pretty easy, because it shows you where flow is, so you want flow to go out, not in. There's an arrow that says that, that's the way flow's gonna go. Another thing is, the way this works is, that's 2 pieces of plastic. And so what happens is air goes through there, it can open, but then as it tries to draw back, it's really pliable, it closes. So it's pretty simple. The part that's open all the time right there has to be.
That's the only time
So this would go.
that we want to use training on, but if it's just simply air, you wouldn't need anything.
They've done a thoracentesis that created this.
Where would that be?
Yeah, well, that should-
That's a great question. I thought it was in here, but I don't see it. But
And this is the kit that we have here.
This was a kit that was open and not used.
Maybe somebody took it.
Yeah.
So typically this is small.
It should.
What you're
Yeah.
talking
But use- but a lot of times people use it.
But what are you supposed to do?
That's your water seal.
Yeah. He was
This would be just.
order it.
Right.
I know, which was like,
Just a reminder of,
So,
one of the medics come in with one, mid-clavicular, we're using probably a finger of a glove for our valve. So don't pull it off like you're cleaning the patient up when you come in. I've had a doc do that where he walked in and thought he was being nice and pulled the finger off there like he was cleaning the patient's chest off and pulled my
so that's
My chest.
your version of that right there.
Exactly, that's
Okay.
my version of it. We just clip the finger of it off, we stick the needle
Yeah.
through it, then put it into the chest, and it's basically its own little flapper valve.
All right, so next. There we go, so that's the Chinese finger trap. Chinese finger trap, that's where you're gonna suture this into place. Notice it has about 3, it's not real tight, right? The whole idea is that you want it a little bit loose, and so you suture it to the skin, take a healthy bite, then tie that down, then you're gonna have 2 ends, and those 2 ends you're gonna wrap around 3 different times, and then tie it up above that. So the whole idea is it's loose enough that as it pulls back, it's being held in place.